Hi, I'm Dr. Messina. Today we're going to be discussing what happens to you if you need mechanical ventilation during the course of a COVID-19 viral illness. We see it on television all the time. The patient lying there, plastic tube in their mouth attached to some kind of a breathing machine. A few nurses adjusting IVs on an IV pole stacked with all different IV fluids. Monitors behind the patient's head, making these beeping sounds and displaying these squiggly lines. But what does that all mean? In this video, we're going to be discussing it in a step-by-step fashion, from the patient presenting to the emergency room to ending up on a ventilator and all of the aftercare in between. If you do like this type of information, remember to subscribe to the channel and hit the little bell to be alerted to future videos. Of the patients who become infected with SARS-CoV-2 developing COVID-19, 80% are going to be mild. That means they're going to range from totally asymptomatic to feeling like they have a very, very bad flu. 20% are going to require hospitalization, and it's usually due to shortness of breath, decreasing oxygen levels, and dehydration. 5% are going to become critically ill. And should they become critically ill and wind up requiring mechanical ventilation, it increases the mortality significantly. Patients who require mechanical ventilation and a ventilator for standard routine things such as congestive heart failure or pneumonia tend to be on that ventilator from 1 to 3 days. Patients who require a ventilator with COVID-19 tend to be on 11 days or more. Step 1, you're going to present to the emergency room after being ill for just over a week. You'll be very anxious, short of breath, rapidly breathing as well. That rapid breathing is because the gas exchange is no longer adequate at your alveoli. Your lungs have now been swollen, infected, have fluid in them, and thick mucus. It becomes very difficult to continue breathing at that accelerated rate. Your oxygen saturation is going to decline. We all talk about oxygen saturation these days, but I'm going to tell you what it is. It's a measure of how saturated your hemoglobin molecule is with oxygen. Ideally, we're 100% saturated. Most of us with healthy lungs walk around somewhere between 97 and 100% saturation. If we have a chronic lung disease, such as emphysema, it's going to be lower. But your oxygen saturation is going to decline. Your carbon dioxide level is going to rise because gas exchange is no longer adequate at your alveoli. Oxygen in, CO2 out. As your carbon dioxide level rises, you will get anxious. You will start to become disoriented and sedated should it get high enough. Oxygen therapy will be instituted, first starting with simple nasal cannula, then increasing to the masks, and we could get up to 100% oxygen through the mask in the non-rebreather mask, which is the type of thing you see on an airplane with the little empty bag attached to the bottom of it. Should you not be able to maintain oxygen saturation using these methods, the next step up would be a high-frequency ventilation and a CPAP mask. If after all of these measures, we still cannot get an oxygen saturation compatible with life, intubation is going to be required with mechanical ventilation. And you will have had a conversation with an anesthesiologist by this point. However, some of the drugs that are used might give you an amnesia to that conversation. Should you progress, you're going to hear your intensivist say, call anesthesia. Call anesthesia is not anything any bedridden patient wants to hear, because it means there's a ventilator coming up the hallway with your name on it. The anesthesiologist will enter the room, discuss the plan with you. They'll lay you down in the bed in a supine position. It'll be very difficult to breathe because you'll be lying flat. They'll place an oxygen mask over your nose and mouth to deliver 100% oxygen. In order to make it more comfortable for you and decrease the risk of you coughing and gagging and spewing infectious particles throughout the room, you'll be rendered unconscious through an IV. you'll see that anesthesiologist upside down and the nurses and everyone else in the intensive care unit around your bedside. Once you go unconscious, the anesthesiologist will take a laryngoscope, slide your tongue to the left, and expose your vocal cords, which are lying just above your trachea. And that endotracheal tube will be inserted in through the cords into your trachea, and a little balloon cuff will be blown up at the end that'll hold it in place. That endotracheal tube will also be reinforced at your mouth with tape. An oral airway or bite block will be inserted into the mouth to prevent you from gnawing on the ET tube. After you're rendered unconscious and intubated, there's a realization by the entire staff that they could be the last people you will ever see. And it's emotionally distressing to the staff, whether you understand that or not. It's not taken lightly by any of them. Step 2 would be setting up the ventilator. The ventilator is able to deliver up to 100% oxygen. If the ventilator is set at its highest level and you're still not maintaining an adequate level of oxygenation, they will add something called positive end expiratory pressure, or PEEP, to the system. And that will give you a little pressure on exhalation that might help get some oxygen past your alveoli and into your bloodstream. However, should you need a lot of PEEP, it can damage the lung with barotrauma. Step 3, IV therapy. You're no longer capable of eating and drinking. All your hydration is going to be coming from your IV therapy. The IV is also going to be the route of administration for all your medications and anesthetics to keep you sedated. You'll likely get a large bore IV in the external jugular vein in the neck. You might get a large bore IV in the subclavian vein under your collarbone, plus peripheral IVs in your hands and arms. We see that IV pole filled with these bags, and we're going to get into that now as to what that is. We're going to have one IV just for fluids. Another IV is going to be the medication that sedates you, usually something like propofol. You may or may not dream during this time. However, some patients do express vivid dreams, while others will say they remembered seeing the anesthesiologist come into the room, and the next thing they knew, it was days later. Because the COVID-19 viral illness is associated with clot formation in almost every organ system, another IV is going to have an anticoagulant in it. That anticoagulant is going to prevent clot formation, which is a good thing. However, it also increases the risk to bleed. You could have a brain hemorrhage. You could have oozing and bleeding from the nose and gums, and from all those little IV sites. You might have an IV for antivirals or antibiotics. Your blood pressure could become very labile. You could drop the blood pressure to critically low levels. Therefore, another IV might be established to give you pressor agents that give a little tone to your vascular system and increase your blood pressure. And conversely, some agents that might lower the blood pressure and ease the work of the heart, which is now trying to circulate blood to rigid lungs. Another line that you might get is an arterial line, depending on how unstable your blood pressure is. An arterial line will be placed usually in your radial artery by your wrist. That little pulse that you feel at your wrist. That'll give a beat by beat representation of your blood pressure. Step 4 will be considerations for excretion and elimination. A Foley catheter is going to be placed in your urethra, going into your urinary bladder, and that's going to collect your urine. There will be also consideration for inserting a rectal tube to collect the stool. Step 5, alimentation. Like I said, you're not going to be eating and drinking while you're intubated, so we have to give you nourishment. Initially, a nasogastric tube will be inserted in through the nostril, going into the stomach, and liquid nourishment will be delivered. However, after a certain period of time, it becomes unhealthy for your upper airway, and the delicate structures in your nasal passages to have this tube resting in there. So consideration will have to be made to put a gastrostomy tube in, or a PEG, where a puncture is made in the skin above your stomach and a tube inserted into the stomach, again to give you liquid nourishment. As I stated earlier, the average patient who is on mechanical ventilation for a COVID-19 viral illness remains intubated for 11 days on the average. Should it get close to 14 days or predicted to go well beyond 14 days, plans will be made to perform a tracheostomy. That would make a hole in the lower part of your throat, just above your sternal notch, and a plastic appliance will be placed in there to allow the ventilator to be hooked to that tracheostomy. The reason for this is the endotracheal tube through your mouth will put pressure on your trachea, and the trachea will get weakened where that little cuff was that I discussed holding it in place. So weakened that it will thin out. It's called tracheal malacia, and it's a risk for your trachea to actually perforate or rip open in that spot. So after 14 days, they're going to consider doing a permanent trach. Now, during the course of all this, you're not going to be just lying there on your back the whole time. So the nursing staff is going to be turning you several times a day. Plus, you might end up prone, in other words, face down, because they found that the oxygenation improves when somebody is placed into this position. As you're being moved, there's the potential to disrupt all these IVs that I discussed. There's a potential to disrupt the endotracheal tube in your trachea. And there's a potential for the patient to become completely hemodynamically unstable. There are just some patients that cannot be turned. They just can't tolerate to change of position. If you're fortunate enough to get extubated, you're not going to be able to just sit up at a bed and start walking down the hall. There's going to be a lot of muscle wasting. There's going to be a lot of rehab required to regain your muscle tone and your muscle strength. You're going to have to learn how to walk again, how to balance again, how to use your arms and legs. Some patients actually had to learn how to eat again. So it's not just a simple process should you have a prolonged intubation and mechanical ventilation. I hope this video gave you some insight into just how significant it is should somebody progress to respiratory failure requiring intubation and mechanical ventilation. It's a very labor-intensive process and a critical situation for you. Up until now, the best things we could do to avoid this was to stay indoors and use masks. But now we have several vaccines available, including the newer mRNA vaccines, which give a very, very high level of immunity and have thus far a very good track record for safety. And yes, you can get the vaccine and you can have a breakthrough and you can end up on a ventilator and you can even die. But the odds of it are reduced dramatically by taking the vaccine. I hope this was helpful and have a good day.